Hello everyone. Welcome to the White Army Comprehensive Clinical class. The White Army is privileged to have Professor Guruprasad, HOD of Neonatology, JJMMC Davanagere, as a teacher and mentor today. A warm welcome to you, sir.
Thank you.
Ashray Patel, sir, will be, Ashray Patel, sir, has volunteered to present a clinical case on neonatal jaundice. Welcome to you, sir.
Yes, thank you, sir.
I
So,
welcome all the attendees to the session. With the permission of mentor, we shall begin the session.
can I start the presentation, sir?
Ashray, can I just speak for 2 minutes before you start?
Yes,
the
sir. Sure, sir.
I think, good evening, everyone. At the outset, I'd like to thank the White Army office, especially Dr. Ashray, for inviting me on several occasions to be a mentor for this particular teaching program. This is the third session in succession. Last December, we had Art of Newborn examination, subsequently approach to unconjugated hyperbilirubinemia. And this particular topic, neonatal cholestasis, was pending for quite some time. I was also busy with some events. So it got postponed on several occasions. Meanwhile, the resident was not keeping well last week and it got postponed to this. So I really feel very honored and privileged to be part of this White Army teaching curriculum that is happening for the postgraduates. Just before this session, I was talking to our teacher. I welcome Dr. Srinivasan from Pondicherry, who is a teacher of teachers, who is more than any student attending almost all the sessions. It is always pleasure having Dr. Srinivasan sir for any of these programs. So I was just talking to him. We do deliver talks in different conferences. Just last month I was in Bangalore for NeoCon and then Pedicon. But there is nothing like doing a case discussion for the postgraduates. That's a very satisfying session. So let me make it very clear what is the agenda for today before Dr. Ashray presents the case. Friends, today's topic is a very, very complex topic. I think as a PG, when you are working in the ward, the moment you are faced with the case of neonatal cholestasis, you feel very nervous and totally lost in the case. And it is not really so. Once you have really understood the subject, made a very detailed reading and understood the topic thoroughly, it can be made more simpler. So the whole agenda for today is to make this complex topic more simpler, more practicable. Before we start, I just wanted to highlight that neonatal cholestasis is a global problem. The recorded incidence of neonatal cholestasis is about 1 in 2,500 live births. This is world data. And it accounts nearly 1/3 of the hepatobiliary diseases in pediatric population. That means if somebody here to today's session would have learned 1/3 of the hepatobiliary system in your PG curriculum, as common a problem as it is. 1/3 of it. And it was thought to be rare, and we were labeling a lot of these cases as idiopathic neonatal hepatitis. But with available of DNA sequencing, a lot of causes have been explored. Probably one of the largest series that is available is from the Center from King's College Pediatric Liver Unit at London in UK. They have studied over 13 years period a total number of 1,625 infants with neonatal cholestasis, and 40% of the cases have been attributed to the hepatitis, idiopathic hepatitis. About 30% are biliary atresias, and about 10% is alpha-1 antitrypsin deficiency, 5% each of progressive familial intrahepatic cholestasis, and total parental nutrition associated cholestasis. The remaining all constituted about another 15 to 20%. That means now there is available data across the globe. So before we start, what is this cholestasis? Neonatal cholestasis refers to obstruction to the flow of the bile. Partial or total obstruction to the flow of the bile. As a consequence of this, the bile, which contains products like bilirubin, bile acids, cholesterol, everything, will start accumulating in the liver and finally in the serum, causing the damage of the liver and leading on to a very classical triad of conjugated hyperbilirubinemia, passage of high colored urine, with or without passage of pale colored stool. This is the triad. This is a brief introduction for the topic. before Dr. Ashray takes over. In the course of presentation, the plan is this. I request Dr. Ashray to present the case in a minute. Then subsequently, at the end of his history taking, let us have some discussion of relevance with respect to antenatal history taking, intranatal and postnatal histories. Then clinical approach to conjugated hyperbilirubinemia. I think most importantly, the participants are waiting how to differentiate hepatitis from extrahepatic biliary atresia. Then how to make a laboratory diagnosis, the biochemical tests, hematological tests, imaging and special investigations like HEDA scan, ERCP and MRCP. The final word is the liver biopsy. Then arriving at an appropriate clinical diagnosis and what should be the differential diagnosis. Before we conclude, let us have principles of management of neonatal cholestasis. What are the prognosticating factors for on long-term outcome in this? What are the surgical options for extrahepatic biliary atresia? How much facilities are available in a country like ours? Finally, before we take home the message, neonatal cholestasis, the yellow alert plea of a baby who is suffering from extrahepatic biliary atresia. With this brief introduction, I now request Dr. Ashray to take over and start presenting his case for the day. Dr. Ashray, please take over.
Yes, sir. Thank you so much, sir. Thank you so much for the brief introduction. And we also welcome Dr. Srinivasan, sir, to the session. Welcome, sir. It is very privileged to have you on our channel, sir. So, with this, I would like to start the case. This case is of a baby of Miss ABC. Date of birth of the baby was 16/05/2021, and on date of examination was 14/06/2021. She presented to us on 28th day of her life, the child being a boy child hailing from Bangalore, informant being mother. The chief complaint was passage of clay color stools from one day. And mother also complained that the child is not gaining weight adequately. Coming to the maternal history, the age of the mother was 25 years, born out of non-consanguineous marriage, gravida 2, para 1, living 1. 3 years spacing was present, mother blood group being A positive, pregnancy weight gain was 10 kgs. The BMI of the mother was 21.6. Then coming to the past obstetric history, the other 3 children are healthy children. The other 2 children, the other living child is healthy, sir. No such complaints in the other child. And the child is presently, the other child is presently 3 years old and doing fine. Coming to the present history, coming to the antenatal history of the mother, it was by spontaneous conception, birth order of 2. The UPT was confirmed at 7 weeks of life, and it was a booked case. And antenatal visits were 5. Coming to the first trimester history, dating scan was done, folic acid supplements were taken, and no other history of fever, rash, excessive vomiting, or any radiation exposure was present. Coming to the second trimester, quickening was felt at 18 weeks period of gestation. Iron, calcium, and folic acid supplements were taken. 2 doses of tetanus toxoid was taken. Anomaly scan was done and was told to be normal. And there was no other history of burning micturition, bleeding PV, or leak PV, or pain abdomen documented. But the mother was diagnosed to be gestational, known to have gestational diabetes mellitus in the second trimester, sir. And subsequently, mother was started on a diet control as well, and other antenatal scans done for anomaly scans done were normal. Coming to the third trimester history, the mother continued to pursue fetal movements. Iron, calcium supplements were taken. Growth scan was done and it was told to be normal. Weight gain during the pregnancy was 10 kg. Coming to the natal history, there was no history of PROM, foul smelling discharge, meconium staining of amniotic fluid. Baby was delivered by normal vaginal delivery. Gestation age was 39 weeks plus 3 days, and baby cried immediately after birth. But postnatal history, then the baby was noticed to have some respiratory distress was present, and in view of the same, the baby was shifted to NICU. There was a history of stay in the NICU for 1 day, and initially the baby was put on CPAP for a duration of 4 hours in view of respiratory distress. As the respiratory distress further settled down, slowly it was weaned off to oxygen support, and by next day, feed was established with the mother and baby was shifted to mother's side.
Actually, the slide you are sharing is not moving. It is standing at natal history only.
Yes, sir.
Please go slowly and yeah.
Yes, sir. And yes, sir. So that was the postnatal history part, sir. So after that, the feed was established.
Share the screen. That slide is not coming. Yeah.
Yes, sir. That slide, it is with the presenter, sir. I currently don't have that slide. That is why I'm not able to share it, sir. Okay. Sorry, sir.
Because it is not visible for us. So yeah, go. It's all right. Yeah.
Okay, sir. So that was the complaint. That was the postnatal history, sir. And after that, the subsequent history was fine. The child was monitored for hypoglycemia episodes. There were no further episodes of hypoglycemia. And the child, after the 4th day of life, the child was discharged from the hospital along with the mother. Presenting complaint was history of passing of clay color stools from 1 day, and on the present visit, mother also tells that the child is not gaining adequate weight, sir. So this was the history, sir.
Yeah, can you sum up?
Yes, sir. Coming to summarizing the history, this is of a 28-day-old boy child who is presenting to us with the significant neonatal history of stay in NICU for 1 day and mother being IDM. The diagnosis was taken as transient tachypnea of newborn. It was on respiratory support for the initial 4 hours of life with CPAP. Later on, it was weaned off to oxygen support, and then the other history was fine, sir. And on day 28 of life, my mother came with these complaints, sir. Passage of clay color stools with not gaining adequate weight.
I think the history should have been taken in more detail. It's a very superficial history. Just you said that the mother has come to hospital with only 1 day history of passing light-colored, clay-colored stools. And some more light should have been thrown on the stooling pattern of the infant throughout the first 28 days. How long baby passed meconium, what were the transitional stools like, and then when was it really the classical description of golden yellow colored stools and how the color changed. I think that is a very important history.
Yes, sir.
And you said the baby is not gaining weight. Whether it
Yes,
is something, anything else was given other than the breast milk. I know we are going to. Yeah. What was the birth weight of this infant?
So birth weight was 3.2 kg, sir.
And the previous sibling is fine.
Yes, sir. Previous sibling is fine, sir.
So, what should be the relevant history taken antenatal and natal and immediate postnatal history in context to today's case discussion? You keep your mind broad open. We don't know yet what is the problem with the baby. It is too early to talk anything about it unless we have seen the infant. Or have you documented the stool color? Any slide is there? Pale colored stool, anything?
No, sir. That is the mother came with the diapers. Diapers in that it was clay color stools, and even on cutting down the stools, it was fully clay colored, sir.
So, what all history will you take? So, what do you think first of all, and what are the relevant history that we should take when you are faced with a case of suspected cholestasis, neonatal cholestasis? I said in my introduction that this is an important clue to suspect something to do with hepatobiliary disease.
Yes, sir. Sir, so first we ask about the jaundice, sir, in the baby, and the color of the jaundice will vary, and then we'll ask about the urine, sir, color of the urine, whether it is high colored urine the baby is passing or not, sir.
And no mention about it when you said at least you would have taken that the urine color was essentially normal. That
Yes,
history should have been written, or it is high color during. There is no mention about it.
Yes, sir. So these are all the points we'll look at in our history, sir, to support our diagnosis.
In any other history you want to take in relevance to cholestasis, what antenatal history will throw a light subsequent to make an etiological diagnosis of that? Relevant antenatal history and family history before that.
Yes, sir. One is the family history, sir. That will support us if any other sibling or if any other member in the family is having the same.
Yeah, because
Yes,
you have a broad group of disorders like metabolic diseases and chromosomal disorders. They can run in families. Most of the metabolic disorders are run in autosomal recessive inheritance, isn't it?
yes, sir.
So there's always a risk. So you should really ask any family history of similar disease, previous sibling history. You said that infant is doing well, grown well, is 3 years of age. Then any family history of hepatobiliary disease, gallstone,
Yes.
pulmonary disease. Any family member is suffering from pulmonary disease.
Yes, sir.
Or
Any other
nutrition deficiency.
any other inborn error of metabolism, like galactosemia,
Yeah.
or then any other surgical things if they have undergone, sir, if any other family members or any sibling, if they have undergone any surgical correction.
So you
all
have to take a detailed family history of liver disease and family gallstones, any operative procedures, any unexplained neonatal or infantile deaths. So all that history may throw a light on the index case. So that history taking is very, very important. Then in antenatal history, anything of relevance, any maternal health status to do with
yes, sir. In the first
cholestasis?
trimester, we'll ask for any infections if mother had any fever or fever with rashes, sir. Because even torches infection can also present with this, sir.
Yeah, the history is very, very important. History of exposure to any infection in early trimester of pregnancy, first trimester. Then
Yes,
history of exposure to drugs and
yes,
any
sir.
toxins, consumption of alcohol, chronic tobacco smoking, amphetamines. These drugs are known to cause liver involvement in the fetus. So, history of exposure to infections, toxins, and medications in the first trimester of pregnancy is very, very important.
Then, sir, coming to the second trimester, if under second trimester in the anomaly scans, if there is any obstructive causes that could have been detected, sir. So anomaly scan can become important in the second trimester.
Yeah, some of the conditions, there could be an antenatal diagnosis of structural heart disease or even hepatobiliary diseases, anatomical abnormalities can be picked up on antenatal scans. Then, so you should have a good scan, antenatal anomaly scan of the fetus. What else?
Then third, in the third trimester,
if the mother's liver is showing any changes or fatty changes, fatty liver in during pregnancy, what does it mean to you? In the index case, if you are faced with a neonatal cholestasis, it is part of the abdominal scan, the anomaly scan that is done. The sonologist has written there are some fatty changes in the liver of the mother. There is association between such changes and most recently evolving diagnosis of progressive familial intrahepatic cholestasis,
yes,
PFIC.
PFIC.
So, yeah, there can be some clues during the antenatal period that this mother had some fatty changes. And what antenatal clues will be there if fetus is suffering from fatty oxidation, acid oxidation defects, FLO? What antenatal illness can present for this?
Not aware, sir.
Maternal preeclampsia. They are at risk. Mothers with eclampsia, yeah, and mothers with LF syndrome are likely to carry fetuses with fatty oxidation fatty acid oxidation defects. So it is very important that you take, just now you said the diabetes. So maternal diabetes will be associated with a rare possibility of neonatal liver disease. Similarly, hypertension during pregnancy and LF syndrome, she had other hematological abnormalities and abnormal liver function tests. Then you have to document that. So I think in this, a lot of clues can be there. I'm taking a good family history, good antenatal history of first trimester, second trimester, the anomalies, routine ultrasound, obstetric ultrasound. Along with that, the rest of the maternal abdominal assessment that will go a long way in arriving at etiological diagnosis subsequently. What is the chance for we say idiopathic hepatitis is the most common cause. What is the mode of the disease most commonly described? 40% of all cases of neonatal cholestasis are due to hepatitis.
Hepatitis.
Yeah. There are two categories in that, sporadic and familial.
Yes, sir.
Sporadic is the most common. 70 to 80% of the cases in idiopathic hepatitis are sporadic cases. There is no obvious past history or family history. Whereas 15 to 20% may have family history of similar disease in the previous sibling or other. Clear? So that history is very, very important. So this is an important clue that whether it is sporadic or familial hepatitis. What is the chance for recurrence for extrahepatic biliary atresia?
So recurrence, if in the family member they have, and the recurrence in this particular child, sir.
The risk for recurrence in extrahepatic biliary atresia is the same as the general population. There is no added risk for the next sibling. Whereas the risk for hepatitis, especially familial variety, the risk for recurrence is pretty high. Clear? Fortunately, this sporadic form of idiopathic hepatitis is the most common, and majority of them outgrow this problem by the time they reach late infancy or in the second year of life. When nature has made something bad, coincidentally, there will be a good solution that we have to look for in that. Most of them will recover with advancing age. Clear?
Yes,
so
sir.
it is very important. I expected it to be a more exhaustive history taking for this case. So,
yes, sir.
Relevant family history, antenatal, natal. What about natal history?
So natal history, again, sir, in case of if the child is had any exposure to infectious or like any stay in NICU, so one of the cause can be that, sir. Postnatal neonatal sepsis itself can be a cause for the neonatal cholestasis, sir.
Yeah, another important thing is history of events in the delivery room is equally important. Unexplained asphyxia in the delivery room, all that hypoxia-induced liver injury can aggravate or exacerbate underlying liver disease. So, a normal events in the delivery room, normal Apgar score, no need for resuscitation is always reassuring. And
yes,
what about the birth weight and in the delivery room?
Birth weight, low birth weight.
So this is the classical teaching, infants who are born with intrauterine infections,
Yes,
and
sir.
infants who are born with growth restriction first trimester, maybe syndromic babies, all that lethal or near lethal syndromic babies, they are born low birth weight and also growth restricted. Most of the intrauterine infections, these babies will be growth restricted. So low birth weight is an important clue. This baby is 3.2 kgs, you said. So if the baby is born low birth weight, you have to have small subgroup of babies. Whereas all other conditions for neonatal cholestasis, the birth weight may be essentially normal. And in fact, babies with extrahepatic biliary atresia are born with a normal weight, and they are absolutely normal at birth. There will not be any clues. See, when you are faced with a situation like this, you categorize them as intrahepatic and extrahepatic. Even the latest Nelson very clearly says you approach the case as intrahepatic cholestasis and extrahepatic cholestasis. And extrahepatic cholestasis, the prototype of that is extrahepatic biliary atresia.
Yes,
whereas intrahepatic cholestasis, either it can be due to hepatocellular disease or intrahepatic biliary duct disease, isn't it?
Yes, sir.
Hepatocellular disease can be of infectious origin
Metabolic.
Of metabolic origin, maybe syndromic origin, maybe hypoxic origin, maybe vascular origin, isn't it? Or toxic origin. It's a very complex disease. That all broad group will be subgroup. When there is no apparent cause, that you call it as idiopathic neonatal hepatitis. Whereas intraductal problem, intrahepatic but intraductal is, the classical example is Alagille syndrome, which we'll discuss in the course of the discussion. So you have to keep your mind very open. So there is no mention about urine color in this infant. You said that the stool color, that too 1 day history. And what is something called as benign cholestasis in the newborn?
Not aware, sir.
Yeah, this is a very common scenario, especially babies who have failure to thrive in the first 2 to 3 weeks, or who are top-fed, all that. They tend to pass the present with a failure to thrive and passage of light-colored or even sometimes near alcoholic stools and little dark urine, confusing you for the diagnosis. And most of these infants will outgrow this problem by 3rd or 4th week. So there is something like a while sludging in these infants may not be necessarily a biliary tract disease or primary hepatocellular disease. Don't you see so many infants who are top-fed, all that formula-fed, the pad is brought by the mother with light-colored stools. You get a shock whether I am faced with any of the hepatobiliary disease. So good number of times these infants will start passing stools normally. Later. So you should be familiar. Can you really describe what is the stool color in the first month of life?
Stool color in the first. So it changes with the type of milk we are feeding the child, sir.
Exclusively breastfed babies. What is your idea of stools in exclusively breastfed infants?
Sir, greenish yellow.
First 3 to 4 days they pass meconium, first 48 to 72 hours they pass thick viscous meconium, which is dark green in color.
Yes, sir.
Then 4th to 6th to 7th day they pass something called as transitional stools.
Transitional stools.
They are not exactly yellow, they are light green in color. There is an overlap of yellow and green. There is a mixture stools, green colored stools. And only 2nd week onwards, the infant starts passing golden yellow colored stools, isn't it? The classical description of stools, because today we are discussing something to do with urine and stool. This is the teaching that we do. Golden yellow in color, seedy in consistency, and musty in odor. You should smell the stool of an infant who is breastfed. This is the description. They are not palm stools. They are as such watery or semi-solid in consistency. And all these infants will pass about anywhere from 3 to 20, 30 stools a day. Or they may pass once in 2 days, 3 days. Both are normally acceptable variations in the stooling pattern. As long as the infant is thriving well, feeding well, gaining weight when you check every 2 weeks, you need not really worry about the frequency of the stool. But the stool color will be golden yellow in color, seedy in consistency, and musty in odor. Clear? So there is no need to be anxious. So such a golden yellow color, just in 1 day it won't become white, isn't it? So the history should have been very, very important. When did the mother notice the change in stool color? That will tell probably at what time postnatal age the baby started having the problem.
Yes.
Then what about the urine in the newborn? Urine?
So urine, so if in case of cholestasis picture, we tend to have high colored urine, sir. Or
normally you do pass light yellow urine, very normal in the initial few days, because they tend to pass concentrated urine and they start diuresing in the later part of the first week of life. Then it becomes more clear. If they are adequately fed, adequately hydrated, the urine color is pretty very normal, no colorless urine, isn't it? Yes, and it won't stain the diaper. As against that, in case of cholestasis, the baby starts passing dark urine and staining the diapers, isn't it?
Yes, sir.
When does the physiological, when is jaundice a concern? There is no mention whether this mother noted that the baby is looking yellow.
Yes, sir. Actually, mother came with these complaints, sir, but on examination, there was lemon yellow tinge in the sclera, sir.
Yeah. So mother never complained. At least you should have mentioned that in presenting complaint. There is no history suggestive of yellowish discoloration of the baby or passing yellow colored urine or red colored urine.
Yes, so passing high colored, there was diaper staining, sir, with this thing, sir, high colored urine.
So when do you say that when is the jaundice of concern in the newborn? Let us not before we proceed. What do you call it as prolonged unconjugated hyperbilirubinemia? Prolonged, that is the most common, you know.
Yes, sir.
When do you say it is neonatal cholestasis? Let us make it more simpler.
So neonatal cholestasis, we can tell when the direct or conjugated bilirubin concentration is more than 1 gram per 1 mg per deciliter, sir, or it makes up more than 20% of the fraction, then we can call it as neonatal cholestasis, sir.
Yeah, you are right. That is a biochemical definition. So let me repeat it because we don't know the bilirubin value. If the direct bilirubin is more than 1 milligrams per deciliter, when the total serum bilirubin is less than 5 milligrams, or more than 20%, when it is more than 5 milligrams per deciliter, then you call it as conjugated hyperbilirubinemia. That is an important element of cholestasis in the newborn. Clear?
Yes, sir.
Maybe the duration of the disease, when do you say it is neonatal cholestasis?
So more than 14 days.
If the jaundice is persisting, for most common cause of jaundice for beyond first to 2 weeks is unconjugated hyperbilirubinemia. I think we discussed in the last class about this. And most common cause for that is the breast milk jaundice. It's a diagnosis of exclusion. The other important causes are blood group incompatibility, Rh immunity disease, ego immunity disease, concealed hemorrhages, cephalohematoma, subgaleal hematoma, congenital hypothyroidism. Then we have Gilbert's disease and Figler-Nazar. These are all conditions which presents for unconjugated bilirubin, which is not the topic for today. But you should have ruled out that it is not unconjugated hyperbilirubinemia before you proceed. If the jaundice is persistent beyond 2 weeks, along with that baby is passing high colored urine and or passing pale colored stools, then you label it as neonatal cholestasis. Is it clear?
Yes, sir.
That's both a clinical and a biochemical definition as we discussed. Anything else? So are you clear? What all is to be taken? I think I said it is a very complex case, neonatal cholestasis. It needs very meticulous history taking. So soft clues in the antenatal history taking, family history may give you a clue in the etiological diagnosis of the present case. So probably I keep telling as a neonatologist, no other condition, antenatal history and family history will be of relevance as we do it for neonatal cholestasis. So please do more, much better homework when you are faced with the case of neonatal cholestasis. So what do you think with this brief history available? What are your possibilities before we go to examination?
Yes, one of the possibilities is neonatal cholestasis with the mother telling one passing of clay color stools with the change in the color of the stools from past 2 to 3 days with staining of the diapers. And the cause we'll have to think of for neonatal cholestasis, as said, it can be either hepatocellular or obstructive causes, sir. So one thing which we shouldn't miss in the early part of life is biliary atresia, because surgery can save the life of the baby. Other causes with this significant neonatal history, one thing we can think of is sepsis, sir, in this child. That could have contributed to this cause, sir.
Yeah, that's what I said in the beginning. Benign neonatal cholestasis related to faulty feeding, low-grade sepsis in the newborn, especially urinary tract infections, all that they can present with a short period of light-colored stools, light-colored urine, and biochemically there may be conjugated hyperbilirubinemia. Once you treat the underlying cause, the baby will outgrow that problem. Clear? Unless you have examined this infant, you may not be very sure. Always, as a clinician, we try to keep the possibility of more benign conditions and, most important, potentially treatable. And what is important in cholestatic newborn is urgency to make a diagnosis. What do you think? The mother has come to you at the right time, or she should have come a little early?
Sir, within first 60 days is the golden period to treat the neonatal cholestasis, sir. So at present, she has come at the times wherein the child is still under treatable conditions, sir.
Reasonably, in an Indian setup like ours, I think she has come at the right time. Probably because the infants are cared in the dark room at home, the jaundice goes unnoticed by most of the family members. And they always, and these infants will have physiological photophobia, and sometimes babies will be dark skinned. So mild jaundice may go unnoticed by the family members. Sometimes when they bring the nappies out of the dark room, they may see that the stool color is looking abnormal, and that seeks attention. I think I am quite convinced that this infant has come at reasonably good time. Coming much earlier doesn't make any difference. At least she has not come late. She has come at the right time. At 1 month, if the mother is presenting you, this is the golden time for you to really think, give benefit of doubt for treatable causes, and rule out any serious diseases like biliary atresia.
Yes, sir.
Any questions come to your mind? I know your friend had prepared for this. She has any doubts, any questions?
So
you don't know much about the history of gaining adequate weight, isn't it?
Yes, sir.
We don't know what was the birth weight and what is the present weight.
Yes, 3.2 kg was the birth weight, sir. And the present weight has actually, it has not even reached the birth weight yet, sir. Present weight was around 2.8 kg, sir.
What was the feeding behavior of the baby in the first 28 days?
Sir, in the first 28 days, initially 1 day there was NICU stay, sir. Then the feed was established with the mother. After that, the child was exclusively breastfed, sir. No other extra formula feeds or other cow's milk was given for the child, sir. So the child was exclusively breastfed after that, sir. And after that, child used to pass daily urine around 6 to 8 times, and the child used to sleep post feeds for 1 or 2 hours also, sir.
Then going with the history that you presented, the baby hardly had any major issues in the neonatal ICU. Am I correct? Just 1 day history like any other infant, and immediately baby was started on breastfeeds and shifted to mother and discharged.
Yes, sir.
And baby didn't have really a very stormy NICU course and a good weight. And how do you explain significant postnatal weight loss and babies passing light-colored stools?
Yes, sir. So underlying
what I said before you really,
low grade infection in the child could have caused this not gaining adequate weight and this picture, sir.
Yeah, I think you are also facing a similar problem. Probably all the units across the state are facing. We have a syndromic diagnosis. What is it? Low milk transfer, significant postnatal weight loss, dehydration, dyselectrolytemia, suspected septicemia, hyperbilirubinemia, plus or minus azotemia. So, once the mother is not secreting milk and there is poor lactation management, the infant fails to gain weight. 3.2 kg baby, by 28 days would have expected the baby, we have seen them crossing 4 kgs by 1 month.
Yes, sir.
So this baby, why I am telling this?
Yes.
Yeah, unless there is adequate substrate in the gut. What you should remember is, bile flow in the first month of life is supraphysiological. There is aggressive flow of bile in the first month of life. If there is no substrate in the gut, that no mother's milk, there is automatically there is inhibitory mechanism for bile to flow. Clear? So these infants may fail to pass normal color stool sometimes, or if they may be light colored. You know what is the value of stool color? People in the West practice something called as stool color cards. You are aware?
Yes, sir.
Can you just share something about it?
Sir,
Taiwan has got a wonderful follow-up, and Japanese have done a 19-year follow-up of infants who presented for extrahepatic biliary atresia, operated and follow-up. Clear? They have prepared a stool card chart. This is there in your Nelson textbook of pediatrics. They are graded 1, 2, 3, 4, 5, 6, 7. Clear? One is totally acrylic stools, clay colored stools. Then lightly pigmented, moderately pigmented, green color, yellow, dark yellow, like that they are graded. The parents are given this card even after going home subsequent to Kazai's procedure. They are asked to mark on that what is the stool color that you are seeing. If they are seeing any difference in the stool color, they have to immediately report to the center. That is the importance of stool color in neonatal cholestasis. You can't just go with the passing clay color stools. I think on the subsequent course you may show the stool color. That is the importance. So stool gradually become. Remember, even biliary atresia, it is not completely absent extrahepatic biliary tract. It is an inflammatory response, cholangitis, isn't it? And gradually there is obstruction to the bile duct. It won't happen instantaneously. So initially there is flow of bile. So stool color will be essentially normal. Even in babies with extrahepatic biliary atresia, the infants may pass normal stools for the initial 2 weeks. So it may continue as hyperbilirubinemia beyond 2 weeks, or it can appear for the first time and going on for more than 2 weeks subsequent to 2 weeks. Extrahepatic biliary atresia has 2 forms of presentation. One is fetal or embryonic form. They present in the first week of life itself. So they start passing light color stools, clay color stools in the very first week of life. That accounts to about 20% of the cases. Whereas 80% of the cases of extrahepatic biliary atresia is postnatal onset type. These infants will be apparently normal for the initial 2 weeks. They start passing eye colored urine and light colored stools beyond 2 weeks. And the mean age of presentation is about 4 to 6 weeks. That is the time at which you have to make a diagnosis. So this history is very, very important. How long the stool color was normal? When did it change? How long the urine color was normal? When did it change? What is the course of the clinical jaundice? See, this is a trial. The diagnosis is based on these 3 markers: presence of biliary jaundice, and urine color, and the stool color. Clear? So this baby has lost significant postnatal weight, and I take that's what I said. I see any number of babies, the stool color will be light color, or we don't make a diagnosis of biliary atresia like that. And I said babies with biliary atresia tend to grow fine in the initial first month of life. That is the problem with biliary atresia. They thrive much better than babies with hepatitis. Only when they have significant obstruction to the flow of bile, then they start becoming symptomatic. Are you with me?
Yes, sir.
So whenever you are faced with just passing light color stools, think of more benign causes of neonatal period. And as you rightly said, it can be low-grade sepsis also. That is something which is potentially treatable.
Yes, sir.
And when you go for examination discussion, then we'll say how to approach the case. So with the history, the findings are very, very, very shocking. I am convinced that this baby has postnatal failure to thrive, has got some element of cholestasis, which I want to check with the examination of the implant.
Yes, sir.
Yeah. With this, can you go to examination?
Yes, sir. So on examination of the child, vitals, heart rate was 118 beats per minute, respiratory rate was 46 cycles per minute, temperature was 36.7 degrees Celsius, and CFT was less than 3 seconds, sir. Anthropometry, head circumference was 36 centimeter, length was 49 centimeter, and weight was 2.78 kg. On doing head to toe examination, sir, then that is when we noticed that there was lemon yellow colored icterus notice, sir, in the eyes, in the sclera, and rest of the examination, head to toe examination, was normal, sir.
Do you?
Going to,
Yeah.
yes, sir.
Is there any difference between the jaundice that looks in routine unconjugated hyperbilirubinemia and cholestasis?
Yes, sir.
Now, how
In
do you
case of
differentiate?
cholestasis, it will be greenish to lemon yellow in color, sir. Oh,
The
there it
greenish
is.
tint will be there. It won't be the type of yellow that you see in unconjugated hyperbilirubinemia.
Yes, sir.
We have taught you the famous rule of cephalocaudal progression of jaundice in the assistant neonatal jaundice, whereas the tinge of jaundice is very different in cholestatic jaundice. Yes.
Yes, sir. Systemic examination, on doing abdominal examination inspection.
I think we'll take a pause. In general physical, before you take systemic examination, keeping in mind cholestasis, what is the relevance of examination, general physical examination of head to toe?
Sir, on head-to-toe examination, one is the icterus that we can notice, sir, and the color of the icterus as we have already seen, sir. And then to give a clue to etiology, other things can be noticed, sir. Like in case we are suspecting tortuous infection, we can have microcephaly, we can have cloudy cornea, all those supporting evidences can be there, sir. Like, and if we are suspecting like any...
You have to mention no stigmas of intrauterine infection, like variation in the head size. You can have both hydrocephalus and microcephaly, whether it is rubella or toxoplasmosis, isn't it?
Yes, sir.
Cutaneous rashes, petechiae, purpuras, mulberry elfin rash, isn't it?
Yes, sir. All this supporting evidence we look for in head-to-toe examination, sir.
What else other than intrauterine infections?
Sir, other than then again, if we are thinking of any syndromic association, we look for any dysmorphic faces.
Yeah.
All those things we might look for, sir.
Though you know it is difficult to make a syndromic diagnosis, especially in low birth weight babies and newborns, at least classical trisomy 21, 18, 13, which are associated with neonatal cholestasis, can be diagnosed in the neonatal period. So look for any dysmorphic features of chromosomal disorders.
Then
carefully look for any evidence of midline defects.
yes, sir. Midline defects.
Optic dysplasias. They may be associated with endocrinal causes of neonatal cholestasis. Panhypopituitarism, isn't it?
Yes, sir.
So midline facial defects you should look for. Then coarse facial features of Alagille syndrome.
Yes,
what are the facial features of Alagille syndrome? What is Alagille syndrome? This is a multi-system syndrome with very soft facial features. Broad forehead, clear?
Yes,
Deeply
sir.
set eyes, mild hypertelorism, sharp chin, the triangular faces it is called as. And these infants will have associated cardiac, hepatic, renal, and musculoskeletal and eye involvement. Isn't it? And in the eye examination, you should have mentioned cataract. Cataract and neonatal cholestasis. What are the conditions?
Galacto.
Yes. Galactosemia and congenital rubella syndrome.
Congenital rubella syndrome. Yes, sir.
Microcornea and neonatal cholestasis. Alagille syndrome. The classical ophthalmic finding of Alagille syndrome may not be seen in the newborn period. Sometimes you may see in later infancy. It is called as posterior embryotoxon. So a good ophthalmic examination is mandatory in these infants. Optic hypoplasias can be recorded in these infants. So you have to look for coarse facial features, ear anomalies, eye anomalies, digital anomalies, isn't it?
Yes, sir.
So general physical examination is utmost important to make an etiological diagnosis. No doubt you said that the most common variety is idiopathic hepatitis. The next common is extrahepatic biliary atresia, and both these may not be associated with any specific findings on general physical examination.
Yes, sir.
Yeah. Systemic
Sir.
examination.
So moving forward to systemic examination, on doing abdominal examination, inspection, shape and symmetry of the abdomen was normal. All areas were moved equally with respiration. Umbilicus was central. No gross swelling, scars or sinuses were present. And on palpation, there was no organomegaly as well noted, sir. No hepatomegaly or splenomegaly was noted, and normal bowel sounds were heard, sir. Other system examination as well remained normal, sir.
Then what did you achieve after systemic examination?
Sir, after systemic examination, one thing noted
No,
was...
what are you looking for? Let us you conclude this. So your systemic examination, abdomen examination is normal?
Yes, sir. So
What
there was
was
no
the liver
hepatomegaly noticed, sir.
No, that is not this thing. Was liver palpable?
Liver...
What are the normal abdominal findings in the healthy newborn?
So normal abdominal findings, tip of the spleen can be palpable, sir. Then liver up to 1 to 2 centimeter below right coastal margin can be there, sir. Span ranging from 3 to 4 centimeter.
So even that much of liver is not palpable. Normal liver was not palpable. There is no mention about it. No, hepatomegaly is a different issue. Unless you record the liver span, complete description of the liver, there is no mention that the tip of the liver is felt 3 centimeters below the costal margin, all that. As you rightly said, the normal findings in healthy newborns, born term gestation, good weight, up to 2 to 2.5 centimeters liver below the costal margin can be normally palpable, especially the right lobe of the liver. In about 15% of the infants, the tip of the spleen may be palpable. In about 5 to 8% of the infants, tip of the upper pole of one of the kidney may be palpable. These are normal palpable abdominal findings. I am interested in this baby who has presented for light colored stools and doubtful high colored urine. What was the liver span? The description of the liver.
So liver span of this child was around 3 to 4 centimeters, sir. There was no...
What is normal liver span in the newborn?
Sir, around 2 to 3 centimeters, sir.
Mm-hmm. Yes. Other systems normal.
Yes.
So what are the abdominal findings that you look for in neonatal cholestasis?
So abdominal
findings neonatal cholestasis. List out all the possible abdominal findings. This is already 1 month infant.
Yes, sir. One is hepatomegaly can be there, sir. That can be one of the associating findings, sir. Other thing that can be possible is like in inborn error of metabolism, if you are suspecting both hepatosplenomegaly, both can be present, sir.
So there can be hepatomegaly or hepatosplenomegaly.
Yes, sir.
Hepatomegaly is seen in about 40 to 60% of babies with hepatitis when you make a diagnosis.
Yes, sir.
And a similar percentage of babies who see a splenomegaly. So it is a part of the disease. Whereas in extrahepatic biliary atresia, there will be only hepatomegaly to begin with. Clear?
Yes,
if
sir.
you palpate spleen in the abdomen and you are suspecting extrahepatic biliary atresia, it's almost certain that baby has gone into biliary cirrhosis and developed portal hypertension.
Yes, sir.
Splenomegaly is uncommon in extrahepatic biliary atresia. When it is present, it always speaks of advanced liver disease and the development of portal hypertension. Clear?
Yes, sir. Yes,
so
sir.
your aim of examination of abdomen in the newborn with suspected cholestasis is abdominal contour, visceromegaly, especially hepatomegaly, splenomegaly, and not only the size of the liver, the surface of the liver, the consistency of the liver, isn't it? If
Yes,
the liver has gone into cirrhotic stage, You know what is the description? Firming consistency,
Forming consistency.
granular or nodular surface. The total description should be there. When the liver is not palpable in this infant, you can't really just unnecessarily create such findings. Yeah.
Yes, sir. Yes, sir.
And you have to carefully look for free fluid. So, what is the evidence of portal hypertension in newborn and young infants?
So, evidences of portal hypertension can be, one is caput medusae can be present, sir. Then ascites can be present, so the child would come with distended abdomen can be there. Then dilated veins can be present over the abdomen, sir. Then other evidences like again hepatomegaly along with splenomegaly can be present, or the child can come with hematemesis or passing melena through the stools.
Probably it holds good for all age groups. The classical triad of portal hypertension is splenomegaly of various degrees,
Yes,
ascites, and evidence of opened up collaterals. Symptomatically, they present for hematemesis and melena, that is GI bleeding. And rarely in older infants and older children only you look for caput medusae. Those things may not be apparent in the newborn. Only you can say evidence of opened up collaterals. That constitutes the third component of the triad of portal hypertension at any age group. So this is what you have to look for. I'm really surprised. History is not very, very sound, and examination is hardly contributory. No hepatomegaly, no splenomegaly. And I just started the discussion even before the examination. It looks like one of those low milk transfer, faulty feeding, those things before we take up the investigations.
Yes, sir.
And what else? The heart, what did you look for?
Sir?
In the cardiovascular system examination and cholestasis, you should have done more exhaustive homework.
Hemochromatosis.
Neonatal cholestasis. Because we are discussing cholestasis today, though the findings are not very classical. You have to look for the position of the heart.
Yes, sir.
Position of the heart. 20% of the biliary atresia are fetal origin, embryonal origin. And these are associated with syndromic associations, dextrocardia, situs inversus, asplenia, polysplenia. So you are interested to check whether the heart is on the normal side or on the right side. Clear? That can give you a clue. Probably you are dealing with biliary atresia over hepatitis syndrome. Clear?
Yes, sir.
And just now you listed so many conditions which have associated cardiac associations. What is the congenital heart disease with rubella syndrome?
Sir,
congenital rubella syndrome, what is the cardiac problem?
Cardiac conduction defect.
Patent ductus arteriosus.
Patent ductus arteriosus, sir. Yes, sir.
PDA. Deafness, cataract, and patent ductus arteriosus. Classical triad of congenital rubella syndrome. What is the congenital heart disease in Alagille syndrome?
Septal defects, sir.
Pulmonic stenosis, peripheral pulmonic stenosis, ventricular septal defect, tetralogy of Fallet's. Clear?
Yes, sir.
There are about half a dozen variety of congenital heart disease that are described in Alagille syndrome.
Yes, sir.
So you have to do careful examination of the heart, the position of the heart sounds, any abnormal sounds like murmurs, all that. See, that's how you take a clue on the etiological diagnosis based on your general physical examination findings. Abdominal findings may all that it says neonatal cholestasis. If there is hepatomegaly, splenomegaly, ascites, all that it says is it is a classical case of neonatal cholestasis. It won't give you a clue. So the clue for etiology should be taken on general physical examination, examination of organ of extra senses like ophthalmic evaluation, auditory evaluations, isn't it?
Yes, sir.
General physical examination. Yes. Yeah, next. So that concludes it. Yeah, summarize.
Yes, sir. So this is a case of a 28-day-old boy child born to second-degree non-consanguineously married couple by normal vaginal delivery with no, with significant postnatal history of with no significant postnatal history, and presently child comes with complaints of passage of clay color stools from one day and noticing high color diaper staining by the mother and not gaining adequate weight. So there's probably and on examination there is lemon yellow tinge that is present, sir. So with all these findings, we think this as a probable case of neonatal cholestasis, sir. So, and then on further investigations that we had done.
So at the end of the examination, we have not become very wiser, very soft, superficial history and examination findings. I think we have to look at what we have in the investigations. So, yes, yeah.
So on investigations, HB was 14.3, total counts was 24,000, sir. Platelet was 2.43 lakhs. There was neutrophilic predominance, sir. Around 75% was neutrophilic predominance. CRP was raised, sir. 22 was present. HTB was 2.2 with direct component contributing to. HTB was total bilirubin was 4 and direct component was contributing to 2.2, sir. Then RFT was normal. USG abdomen done was normal. Urine routine sent had around 5 to urine routine was sent had around more, the pus cells was more, sir. Urine routine sent was 20 to 25 pus cells were there, and then the culture came out to be positive, sir. Urine culture came out to be positive. E. coli sensitive to gentamicin was there, sir. So this baby, it was taken as neonatal and even taken as case of neonatal cholestasis secondary to urosepsis, sir. Initially started on empirical antibiotics, then later on, as per culture and sensitivity, it was treated. The child slowly started, the color of the stools as well changed. So after 4 to 5 days of treatment, slowly the yellowish tinge started to come, sir. So the child showed gradual improvement later, sir. So it was treated with 14 days of antibiotic course, then sent, sir.
So I just, even before you presented the clinical examination, this is the classical presentation of babies, a syndromic diagnosis, a combination of significant postnatal weight loss, low milk transfer, clear?
Yes, sir.
Dyselectrolytemia, hyperbilirubinemia, metabolic acidosis, and they usually present for either unconjugated or mixed hyperbilirubinemia and an element of sepsis. And urinary tract infection in the newborn is certainly one infection, deep-seated infection, which can present with the way it presented. So I'm not surprised with the diagnosis, but I was expecting a different case for this session. And once you are held up with that, how can you proceed further for evaluating neonatal cholestasis?
So, neonatal cholestasis.
Yeah.
Initially,
that's your last but one slide. Am I correct?
Yes, sir.
So
initially, the way we proceed with neonatal cholestasis is we do a USG abdomen, sir, to look for any the extrahepatic cause of neonatal cholestasis is there or not, sir, because that becomes the
methodically. We have a case. We have a case of neonatal cholestasis. How do you methodically investigate? You don't straight away go to ultrasound abdomen.
Yes, sir. First is the
biochemical investigations, hematological investigations, imaging tests, and any special investigations.
Yes, sir. First is the hematological and biochemical investigation we do, sir. So, along with sending for both urine as well as blood culture, sir, because both of them as well are contributing causes to the thing. So, hematological examination will tell that. Then, biochemical examination we send for LFT, sir, so that it matches the definition of neonatal cholestasis, sir. Either more than 20% when it is less than 5 milligrams per deciliter, or more than 1 when it is less than 5 milligrams per deciliter. And then comes the imaging, sir. In the imaging, first is the USG abdomen, sir, to look for any obstructive extrahepatic biliary cause of jaundice, sir. if we can rule out that, then the emergency part is ruled out, sir, because that is a surgical cause that needs to be treated within the 60 days amount of period of life. If the USG abdomen comes out normal, then we'll have to go ahead and do other tests like HIDA scan might be required, sir, to prove for
when you
look
are
for.
Ashray, when you are faced with a baby with neonatal cholestasis, you have to approach this way. Is it a sick newborn with neonatal cholestasis, or is it a well baby with neonatal cholestasis?
Yes,
if you have a sick newborn with neonatal cholestasis, conditions that should come to your mind should be sepsis. Second one should be torch infections. Third is inborn errors of metabolism, galactosemia, fructosemia, and those things. Again, they are at risk to develop pulmonary sepsis. Clear?
yes,
And you start your examination with urine routine, and including reducing substance. When you have high index of suspicion,
yes, sir.
In the neonatal period, they can present for acute hepatic encephalopathy, acute hepatic failure. Clear?
Yes, sir.
Yeah, the spectrum of disease of neonatal cholestasis is totally asymptomatic to a frank case of acute encephalopathy, acute liver failure. In between is your hepatomegaly, splenomegaly, portal hypertension, all that. Don't be carried away. You have to have a very methodical approach. So urine examination routine, especially with reference to reducing substance. Clear? Then microscopy to rule out urinary tract infection and urine for culture and sensitivity. And complete blood counts, including blood culture. You look for any neutrophilic cell, leukocytic reactions, and look for C-reactive protein. Look for other inflammatory markers, because aggressively, if you treat infection, benign cholestasis associated with sepsis is taken care. I said, a small percentage of babies with sepsis can present like this. After you give an effective course of antibiotics, the babies will start secreting bile and the stool color will revert back to normal. So complete blood counts, blood culture, urine culture, and liver function tests.
Yes.
Liver function tests, you have to classify them. The enzyme, you have to assess the enzymes, isn't it? SGOT, SGPT, they gave an idea of hepatocellular liver disease. These are significantly increased in conditions where there is hepatitis as an important element. Whereas where there is obstruction is an important element, like in extrahepatic bioatresia, all that, alkaline phosphatase and gamma glutamyl transpeptidase are significantly elevated.
Yes.
One speaks of the liver function, the other speaks of the secretion or the flow of the bile.
Yes,
so one gives an idea of what is the severity of obstruction, the other one, the health of the hepatocyte.
Yes.
Then other investigations will speak of
much can we rely on ALP and GGT, sir?
Yeah, they give soft clues. I'll come to that. The most evolving condition is progressive familial intrahepatic cholestasis. First type is also called as Bayer's disease, which was earlier. Call it clear.
Yes,
these symptoms will be totally anectric or mildly ectric. They will have almost unacceptable pruritus. That is the presentation. Neonatal cholestasis with significant pruritus. Clear? And on examination, GTT will be normal or low impact. So it all depends on the bile acid metabolism pathways which are affected, the receptors that are affected, all that. So these biochemical markers will give a fair idea for the etiology also. Because when you are talking about neonatal cholestasis, liver function tests are very, very important. Similarly, we estimate albumin, blood sugar, and prothrombin. They all give an idea about the synthetic functions of the liver. If there is hypoalbuminemia, that means the liver is significantly affected for quite some time, isn't it?
Yes, sir.
Persistent hypoglycemia is also something worrying. So, metabolic workup, enzyme studies, and synthetic functions of the liver. All those, these are all done in all the settings. So, you have to be very meticulously looking at these things. I don't know what was it in the index case. Good liver function test should have been done. Then, so biochemical, urinary examination, hematological investigations. Then you come to the sonographic evaluation, ultrasound examination. What are the classical findings in hepatitis syndrome and in extrahepatic biliary atresia?
So in extrahepatic biliary atresia, there will be dilated bile radicals will be present. So we look for that. In case of hepatitis, there will be hepatomegaly will be noted, sir.
In both, there will be altered texture. But the thing is, in case of extrahepatic biliary atresia, the commonest variety of extrahepatic biliary atresia, there is a triangular cord sign that is described on ultrasound abdomen. Triangular cord sign. That is fibrotic bile duct, hepatic duct in the common bile duct. That gives the echo texture on the ultrasound of the liver. That is a very classical radiological finding. And for that, people recommend high frequency Doppler studies to pick up this ultrasonographic findings also sometimes. Yeah. So, triangular cord sign is the hallmark of extrahepatic biliary atresia. Clear? Otherwise, in both there will be hepatomegaly, there is altered architecture. Clear?
Yes, sir.
Some non-specific findings on ultrasound abdomen. Then
comes the HIDA
significant ascites, all that it gives an idea that it is portal hypertension. That's all.
Yes, sir.
Okay. If you are suspecting extrahepatic biliary atresia, you have to do special investigations.
Yes, sir. Yes,
There is an urgency to make a diagnosis. If this baby has come at 1 month, I think the next 2 weeks are going to be very crucial for establishing the diagnosis and referring the baby for the higher center for a surgical intervention. So, what tests are done when you are suspecting biliary atresia?
HIDA scan.
Extra ultrasound.
HIDA scan can be done, sir.
What is
Hepatobiliary immunodiacetic acid test.
Immunodiacetic acid radioisotope scan, isn't it?
Yes, sir.
So, what happens in extrahepatic biliary atresia?
So the flow will be limited, sir. The dye will not flow through this
Total absence of the dye into the gut.
Yes, sir.
Supporting that there is total obstruction of the biliary network. Hardly anything is flowing into the gut. Clear?
Yes, sir.
It is not 100% sensitive or specific for the diagnosis of extrahepatic biliary atresia, but it is available and it is an important investigation that is discussed for last 2-3 decades. So that's an important tool to differentiate between biliary atresia and hepatitis syndrome. Then,
so then finally is a liver biopsy, sir.
Yeah, people have done even doing a laparotomy and intraoperative ERCP, isn't it? Endoscopic retrograde cholangiopancreatography, and recently people are talking about magnetic resonance cholangiopancreatography. These are more superior and sensitive and specific, unlike HIDA scan. Only the thing is, these investigations can be done only in pediatric gastroenterology centers and where there is a technical expertise and the surgeon, everybody are available for any emergency. Based on that finding, immediately you may have to take the baby for the surgery. Clear? So,
yes, sir.
In a nutshell, the investigations that should be done before liver biopsy. What type of liver biopsy is done? Percutaneous liver biopsy.
Yes, sir.
Percutaneous liver biopsy. How do you differentiate hepatitis syndrome from biliary atresia? What will be the hallmark in hepatitis?
So by histopathology, there will be lymphocytic infiltration.
Yeah, there is lymphocytic infiltration, giant cell infiltration. Earlier description was giant cell hepatitis, idiopathic hepatitis, remember?
Yes, sir.
Whereas in biliary atresia, there will be ductular proliferation and biliary sludging.
Yes, sir.
So there is evidence of biliary bile tracking in the biliary tree.
Dr. Guruprasad, there was a chat box question, very relevant.
Yeah.
That screening, torch screening, why not done? Because there can be intrauterine infection plus subsequent sepsis. So there was a question.
Yeah, I think a lot of other etiological diagnoses can be made by intraoperative cholangiography. We just looked upon as biliary atresia. There is a complex syndrome, extrahepatic disease. There can be perforation of the common bile duct. There can be colorectal cyst. So many other surgical conditions which we have not discussed. It is beyond the scope of today's discussion. Broadly, we have touched upon prototype, extrahepatic biliary atresia, and hepatitis syndrome. So, can you now, in a nutshell, tell how to differentiate hepatitis and biliary atresia from history-taking, clinical examination, and laboratory diagnosis before we conclude and take up principles of management?
Sir,
Ashray?
yes, sir. So, based on history, hepatitis and
Hepatitis accounts to, I said, even in the best center in London, 13 years experience says 40% is hepatitis, 30% is biliary atresia. So 70% of neonatal cholestasis is accounted by that. But it is important to differentiate in our setup because extrahepatic biliary atresia has something to offer. Whereas hepatitis syndrome, the main management will be good supportive care and comprehensive liver supportive care, isn't it?
Yes, sir.
So to begin with, hepatitis syndrome record whether the baby has got low birth weight, intrauterine growth restriction, all that, any strong family history, clear. Whereas hepatic biliary atresia, there is no such family history. It don't recur like that. These infants are born normally. Clear.
Yes, sir.
In hepatitis syndrome, the stool color becomes gradually pale over weeks. It may appear for the first time behind 4 weeks, 6 weeks, 8 weeks, like that. Gradually, it becomes light colored. And urine also gradually it becomes light colored. Whereas in extrahepatic biliary atresia, in a fetal form, jaundice is there from birth. Otherwise, by any time, 2 weeks it will appear. And progressively it becomes pale. And the stools are echolic in biliary atresia. If the stools are consistently pale colored, it favors biliary atresia rather than hepatitis.
Yes, sir.
Okay?
Yes, sir.
And on ultrasound liver function examination, unusually raised ALT and GGPT levels in biliary atresia against enzymes in hepatitis syndrome. Ultrasound findings, triangular cord sign is favoring the diagnosis of extrahepatic biliary atresia. Then HIDA scan will favor the diagnosis of biliary atresia over hepatitis.
Yes, sir.
Then percutaneous, extrahepatic intraoperative retrograde cholangiopancreatography and magnetic resonance. These will add on to the final diagnosis of biliary atresia. Clear?
Yes, sir.
So there was a great concern when we were students like you. We used to see these babies at 2 months, 3 months with advanced liver disease, with cirrhosis, with portal hypertension. Clear? So it is very important the diagnosis in biliary atresia is made latest by 6 to 8 weeks and referred to the center where all the facilities are available. Clear?
Yes, sir. Yes, sir.
So the take-home message should be that how to differentiate hepatitis from biliary atresia. What are
Yes,
the
sir.
principles of management of neonatal cholestasis? I think I will. Yeah.
One is the generalized treatment and other one is the specific management, sir. Coming to generalized treatment, we'll have to take care of the nutritional support to the child, sir. So we'll have to go with the ADK, vitamin ADK supplements. Then we'll have to match up with the calorie requirement. Then, and we might have to add the triglycerides like MCT oil and all, sir.
So the most common problem with cholestasis is there is no bile in the intestine. So there is
Yes.
spotting with the absorption, metabolism and absorption of the fat. So gradually these infants will present for malabsorption and malnutrition, especially
Yes,
fat malabsorption and fat malnutrition. So macronutrient management. See that these babies are initiated and supported for breastfeeding. Please calorie. This is an hypercatabolic state. calculate a calorie requirement about 150 to 200 calories per kg per day, and a protein requirement about 2 to 3 or sometimes up to 4 grams per kg per day. And as I rightly said, there is difficulty in digestion of the long chain triglycerides. You can give these infants medium chain triglycerides in the feeds along with the express breast milk, all that, because they are much easily absorbed and are available for the baby for the energy sake. So macronutrient 150 to 200 calories, 3 to 4 grams per kg per day of proteins. Medium chain triglycerides are preferred in these infants. And as there is problem, all the fat soluble vitamins are not absorbed here. A, D, E, K. Over time, all these infants will develop symptoms and signs of fat soluble vitamin deficiency. A deficiency, night blindness. K deficiency, life threatening bleeds, especially intracranial bleeds.
Hemorrhagic disease of newborn.
E
Yes.
deficiency, they present for neuromuscular syndrome, atonia, sensation abnormalities, lethargy, poor feeding, degeneration of the cord.
Yes, sir.
Isn't it? D is osteopenia, prematurity, pathological fractures order. So you have to replace these infants with fat soluble vitamins until the final word is said. It is recommended that fat soluble vitamins are given 2 to 4 times the daily recommended allowances. Not the
Yes,
routine. 2 to 4 times. I am just not telling individual vitamins. Fat soluble vitamins give 2 to 4 times the daily recommended allowance. Similarly, B complex vitamins need to be replaced. And these B complex vitamins act as cofactor for so many metabolic pathways. And you are asked to give 2 times the recommended B complex vitamins. 2 to 4 times fat soluble, 2 times the B group of vitamins. Is it clear?
Yes, sir.
150 to 200 calories and 3 to 4 grams of protein. So this is about macro and micronutrient management. And what is the problem with this? Because of retention of bile, all that, pruritus is an important symptom in these infants over time. So you have to use cholinergic agents. What are the drugs? What drugs are used to treat pruritus in young infants with neonatal cholestasis?
Ursodeoxycholic acid, sir.
Yeah, UDCA, ursodeoxycholic acid. Number 2, cholesteramine. Number 3, phenobarbital. Exceptionally rare cases, naloxone, morphine group of drugs is also recommended, especially in babies with PFIC, progressive familial intrahepatic cholestasis. Pruritus is an important presentation, and these infants need drugs like this. So pruritus management is very, very important. Then, if these infants have developed portal hypertension, you have to use potassium sparing diuretics, isn't it? And what is the treatment for biliary atresia?
So biliary atresia Kasai procedure, sir.
So it is always Kasai's procedure that is done. At what age you do Kasai's procedure?
Sir, best is to do before 60 days of life, sir.
Usually in the second, latest in the by 2.5 to 3 months of age. Kasai's procedure, it's a diversion procedure. Hepatoportoenterostomy. You have to see that the bile gets into the intestine. It is a palliative surgery. That is not the final word for biliary atresia. If you do it at the right time, you can ensure that these infants grow normally till the end of first and even mid-second decade. The final word for these children is liver transplantation. But if you miss to do Kasai's procedure, Kasai is a Japanese gastrosurgeon who did it for the first time. And a couple of units in Japan have the follow-up of these children for 19 years now. Clear? So Kasai's procedure is done, as you rightly said. That is the reason that slide that we are going to share. There is urgency to make a diagnosis of biliary atresia. And where it is done in Bangalore, if their parents are asked your baby has biliary atresia, where do you refer them?
Sir, in Bangalore, very less centers now, like HCG and all it is done, sir.
Where do you want to send? They will ask, as you rightly said, only a few centers are doing this.
BGS, HCG and all, sir. Yes, sir.
Yeah, couple of centers are doing in Bangalore. Narayan Children Hospital have done. If I'm correct, Ashley Bittu has done. Then HCG has done. Then Chennai, there are a couple of centers. Muhammad Rila and team are doing Kazai's procedure and pediatric liver transplantation. One of the international reputed center is in Chennai. As treating physicians, we should know where to refer them and when to refer them. That is very, very important. So the final word is liver transplantation.
Yes, sir. Yes,
Final
sir.
word is liver transplantation. Yeah.
Sir, for priming, what can we use, sir? What would be the best agent, sir, for HIDA scan? Like there is this thing between either Udka or phenobarbital, sir.
No,
like,
no.
Both of them have the similar.
Both have been tried.
Yes,
Both priming of these infants with 5 days course of Udka or phenobarbital and then doing HIDA scan. And as I rightly said, I reviewed the literature, intraoperative invasive radiological investigations, ERCP and MRCP are point to be extremely useful in making a diagnosis. And you should have a backup facility to do a surgery immediately. That is the important.
Yes, sir.
Yeah, can you read what is written in this slide? And I will take up questions and very valuable remarks from Srinivasan, sir. Yeah,
it is
read this.
I also want to live, doctor. My skin and eyes are yellow. I pass dark urine and pale stools. Nevertheless, I appear well to my caretakers. The inside story is my bile drainage tube is blocked and my liver is on fire. I have biliary atresia and knife is the solution. First 6 of age is the golden period for rescue. Refer newborn babies with persistent jaundice beyond 14 days of age, passage of dark colored urine with or without pale stools, urgent attention particularly to babies who look well and have pale stools, sort out diagnosis in the first 6 weeks of age.
So what is important to remember is extrahepatic biliary atresia is very cheating to the clinicians. These infants will be looking very normal and 80% are postnatal onset. So first 2 weeks they may not present with any symptoms. Urine color will be normal, stool color will be normal. Suddenly they start presenting and very rapidly they progress. By second month, 5 to 6 weeks, they will have almost advanced disease. That is exactly what this poster says. This is a plea that is prepared by the Pediatric Gastroenterology subgroup of IAP, headed by Ashish Bavrekar, Dr. Yacha from SGPJ. It is interesting to note that the SGPJ is one of the centers which is doing a lot of work for almost 3 decades now. They try to create awareness amongst referring doctors. Over a period of 8 years apart, they have seen that these infants are referred instead of at 90 days, now they are referred to them at around 60 days. They say it is a great achievement. So it is important that we create awareness amongst all our colleagues across the state and across the country, where all babies with cholestasis, please see that a person who is knowledgeable in that has seen and ruled out biliary atresia. And if it is biliary atresia, make it a point to refer them to the best center that is available close by and affordable by the parents. That's what I just want to say. I request now Dr. Srinivasan sir to just add on. He has very vast experience.
No, not vast experience. I am only a general pediatrician. Everything has been covered, very well presented, and extremely well discussed. Of course, just because urosepsis was there, it doesn't mean that we must not rule out intra-aortic infection. So that screening has to be done, because it can even urosepsis can occur in a child who is already having some intra-aortic infection. So that investigation was warranted. Otherwise, it's very well discussed and it's wonderful. Thank you.
Any questions? Ashray, from the chat box, you can just check. See.
Into that, sir. Sir, role of liver biopsy they asked and role of MRCP cholangiography they asked, sir.
I made it very clear. These are the newer techniques that have come into practice in the Western world. Intraoperative endoscopic retrograde cholangiopancreatography, magnetic resonance cholangiopancreatography. A lot of studies have been done and they are proved to be more sensitive and specific, unlike the HIDA scan, which was the gold standard for nearly 2 decades. So as there is urgency to prove the diagnosis, we need to have a much better, more sensitive investigation. I think they will come to our country in a short time. These are being discussed in very recent literature on neonatal cholestasis. They should be available. And again, liver biopsy, intraoperative, we just now discussed. You need to do special staining techniques. You need to have a good pathology team, especially experts in hepatic pathology, hepatopathologists to give very good idea about it. There are so many other conditions like PFIC, all that have very specific histological findings. Just looking at the liver biopsy specimens itself, you can arrive at etiological diagnosis. That's something that we need to improve upon in our country.
So next question was, is there any specific protocol that can be followed for the approach, sir, to neonatal cholestasis?
That's what exactly I made it a point to discuss today. I think as a postgraduate, I think still it holds good. Your basic approach is cholestasis, is it intrahepatic or extrahepatic? Extrahepatic, your prototype of that is biliary atresia. I said that there are other conditions like choledochal cyst, rupture of the common bile duct, perforation, those things. Whereas intrahepatic atresias, it can be related to hepatocellular injury or intrahepatic hypoplasia of the bile duct, intrahepatic. The classical prototype of that is Davanagere syndrome. There are many other conditions which are described like that. Then the other conditions are infectious, toxins, metabolic disorders, and those things. That should be the basic approach. And individual condition, there is abundant literature. You can. The whole idea of discussion today is to make it as simple as possible, and you should have a table, 10 differentiating points between hepatitis and biliary atresia. And in biliary atresia, again, 80% are postnatal onset, 20% are embryonal or fetal origin. They are the one which are associated with malformation. It is called as biliary atresia and splenic malformation syndrome, Wasson syndrome. Yeah, that's what I said. They will have situs inversus, asplenia, polysplenia, and so many things. Whereas postnatal onset, the prototype what we discussed, biliary atresia, unless it is specified, it is the postnatal onset biliary atresia. I think your recent edition of Nelson has given a fair account for your examination writing. And when you are presenting a case, you should make a reading beyond that.
That's it, sir. Is torch profile screen also included in the approach? Was the question, sir. I think so. They wanted to ask, should everyone be, all the babies be screened for torch?
Yeah, on examination, you noted that the baby has features of growth restriction, low birth weight, and soft findings like eye findings, cataract, corneal haziness, or cutaneous manifestations, petechiae, purpura, and those stigmas are there. I think you have to order. As a routine, for example, you have to order torch panel, you have to order DMAS for that matter, investigate all babies, all sick babies. We should rule out hereditary, galactosemia, very, very important. Never start, it is said, in a suspected case of neonatal cholestasis, never start breast milk unless you have ruled out galactosemia.
Yes, sir. One more doubt was, like, if the child is presented to us late post 60 days, is Kasai procedure indicated, or should we go for a liver transplant?
No, that the surgeons will decide. There is a scoring system for that regarding the feasibility. What type of biliary atresia it is? Is it type 1, type 2, type 3? You know, the most common variety is type 3, wherein the surgical technique is most complicated, the Kasai's procedure. So it also, the moment I said that the moment you make a diagnosis of biliary atresia, these babies would have gone in for biliary cirrhosis and port liver. So once the babies develop this, where is the question of liver transplantation? Kasai's procedure has become very, very useful to salvage these babies, and neonatal organ transplantation is a rarity even in the Western world. To get such small donors, all that is not an easy job. Doing pediatric liver transplantation, older child, all that is understandable. Neonatal liver transplantation are only a few cases have been reported in literature. So Kazai's procedure is the standard palliative surgical procedure. It is ideally done in the late second or latest in the third month of life, not beyond that. Timing wise, if it is biliary atresia, after third month, fourth month, all that these infants would have a progressive liver disease, and short of Kazai's procedure, these infants with biliary atresia rarely survive beyond second year of age, beyond 2 years.
That's all were the doubts, sir.
And there are no doubts on YouTube, sir.
Yes, sir.
Yes. So, any concluding remarks, Guruprasad, sir?
Yeah, I think Ashray, I appreciate you that you managed to make a
Sorry,
presentation.
sir.
in the
That
absence
was
of
a
your time.
last minute change.
Yeah, I know. Otherwise, you would have prepared better. I expected a little more in your history and examination. I have come prepared for a more, much deeper discussion on this topic. So, because this is something which is not thoroughly discussed in regular classes, but it needs a lot of understanding of the subject. We have not really discussed rare diseases, other causes. I didn't really touch upon parental nutrition associated neonatal liver disease. These are all upcoming topics. TPN is widely practiced, and that is emerging as an important challenge. Then other conditions, neonatal hemochromatosis, and alloimmune pregnancy-associated alloimmune liver disease, ALND. So there are so many new things that are coming in neonatal cholestasis. Please read your Panaraf and Avery's book and Robertson's textbook, and they give a good account of that. So what is, there is a very brief mention because it is not. So what is very important before I conclude, when you are faced with a condition, please see that the life-threatening problem is coagulopathy in these infants with neonatal cholestasis. Before referring them, give them 5 milligrams of vitamin K, communicate to the referring doctor, I am referring the baby. And once the baby is admitted, you start them on micronutrient supplements, and gradually you build up on calories and proteins, restore nutrition, and try to check up. See, you are in Bangalore, you are finding it difficult. Where should I refer the case if this is biliary atresia? We think that we have grown very tall in our profession. We are helpless when it comes to a case like biliary atresia.
Same in Bangalore too, sir. It is too costly for the procedure for most of them to afford as well, sir.
I happened to interact with Dr. Mohammed Rila. He's an Indian-based surgeon in the UK. He keeps coming to Chennai. He has the privilege of doing a good number of pediatric liver transplantation in the world. So he comes and does pediatric liver transplantation at Chennai for various other conditions like alpha-1 antitrypsin deficiency and so many conditions. The final answer is liver transplantation. I think this is one area, gray area, wherein we need to improve upon and develop further. Once again, I thank White Army for this great opportunity. Thank you, Ashray, and the coordinator of this particular activity. I immensely thank my teacher, Dr. Srinivasan, who was with us throughout the discussion. Good evening, sir, and great day. Very good night.
Learning from you.
Thank you, sir.
Thank you, sir. It was wonderful discussion. It was very useful to us. Thank you, Professor Guruprasad, sir, for taking your time and joining us for this wonderful discussion. We could learn a lot from you. It was a great presentation by Dr. Ashray Patel, sir. We could learn a lot from your well-prepared presentation, sir. Thank you. Thanks to all the participants for their active participation. Thank you, one and all.
You can